Good afternoon, everyone. To those that are joining us for the first time, welcome. We're so glad you're here. And to those returning, welcome back. Thank you all for joining the TxRx Echo, brought to you by the Center for Substance Use Training and Telementoring Center, also known as CSTAT, by Be Well, Texas, in collaboration with the UT Health San Antonio Echo program. My name is Angela Riley. My pronouns are she, her, and I will be the facilitator for today's session. A few housekeeping items before we begin. To help us with attendance, please enter your full name, affiliation, and email into the chat. Please remember to stay muted unless you are speaking. We do encourage everyone using the chat and/or raise your hand feature to post questions or share your perspectives throughout the session today. If you are having connection issues, please privately chat myself, the facilitator, or Karen, our IT, for further assistance. As a note, these sessions are being recorded and will be shared on our website. Therefore, to ensure privacy, no personal health information is allowed at any point during the session. And this includes names, addresses, birth dates, or any other identifiable information. At the end of the session, the ECHO team will send out a post-session survey link. We kindly ask that you complete it as it provides us feedback on how to better refine these sessions to better address your priorities. And finally, ECHO is an all-teach, all-learn environment, and we do encourage everyone to participate in the conversation today and raise questions. Let us always make every effort to continue having a space that is respectful and safe for all to learn. So with that, we'll move on to team introductions. I will begin with Dr. Shorter.
Hey everyone, I'm Daryl Shorter. I'm a associate professor of psychiatry at Baylor College of Medicine and the medical director of addictions at the Menninger Clinic. Thanks.
Dr. Shorter, Dr. Weems.
Hey guys, John Weems here, internal medicine doc and addiction specialist here at Community Care at QHC in Austin, and a member of the SHOUT team supporting hospital-based teams around Texas. And excited for Dr. Das's case today.
Dr. Weems. Dr. Chowdhury.
Hello, everyone. My name is Ali, and I'm an assistant professor at University of Texas Health San Antonio. And I'm a family medicine trained and adolescent addiction medicine trained addiction medicine doctor here, working on making an adolescent addiction medicine program.
Dr. Chowdhury. Sorry, let me check my list here real quick, everyone. Okay. And then Dr. Waklu.
Good afternoon, Siddharth Waklu. I'm an addiction psychiatrist at UT Southwestern, director of the Addiction Psychiatry Services here, and director of the Addiction Psychiatry Fellowship at UT Southwestern. Thank you. Welcome on.
Dr. Waklu. And finally, we have our didactic presenter for today. That will be Dr. Crystal Walker. She is a doctorally trained physician assistant and is the Director of Substance Use Disorders Clinical Services at My Health, My Resources of Tarrant County. Dr. Walker.
Thank you so much for that. I appreciate you saying all the words so I didn't have to. Okay, so my sharing request, I know you're working as IT today, Angela. I attempted to share my screen. There we go. All right. We are cooking now. Okay, everybody. So today, again, my apologies for my voice. I am under the weather, as are many individuals as of late. So we're going to try to truck through this together today. I want to talk to you about implementing substance use services in primary care settings. I don't have any disclosures. We're going to talk about kind of why there is a need, what are some of the barriers, how can we integrate, and what are some good resources for everyone. So let's talk about need first. Why are we even talking about integrating this into primary care? Well, there's quite a few reasons. I can put up a lot of statistics stating how few individuals have access to get treatment for substance use, how few individuals are getting medications for substance use disorder. And we've been working for several years now to try to lower barriers, but it doesn't seem to be fully working what we're doing. And this slide is kind of showing some of that in real time. So in December of 2022, we got rid of one of the biggest barriers to prescribing buprenorphine. We got rid of the X waiver. So when we got rid of that X waiver, it removed a lot of requirements for providers to prescribe a life-saving medication called buprenorphine. And it increased the pool of providers available to prescribe that medication from about 130,000 to well over 1 million providers can now prescribe this medication.
Dr.
But
Walker,
when they did a study,
I'm so sorry to interrupt your flow. We don't see the slides right now.
oh my
I'm not
goodness,
sure what
okay,
just happened. Um,
no problem. Let's try it one more
okay,
time. What about now?
okay, access to treatment, the removal of the X waiver. Yes,
Yay.
awesome.
Okay,
Thank you.
perfect.
Thank
Well,
you.
you know what? Everything I said up to that point wasn't even on the slide.
Oh,
So
well, there you
we're
go.
now getting in.
Now we're on the slides. Awesome. Thank you.
I was just talking. Yeah. So now we're getting into what I was wanting to talk about on the slide. So when you look at the time period before December 2022 and after December 2022, so the entire year of 2023, when they took a look at the number of patients who had buprenorphine dispensed, it was almost equivocal. It barely made a difference, if not making a difference at all, removing that X waiver. Now, the one area that it did have a small bump was new patients initiated. So that's the getting a first prescription of buprenorphine in the first 120 or 180 days. But it's pretty sad to see that removing this massive barrier made almost no impact in the reach of getting people who need buprenorphine and medications in general. They're still not being reached. So what is going on? What are the barriers that's causing this? Well, there's a couple of studies that was done. One was a survey directed at specifically family physicians. And 80% of the family physicians that were surveyed, they felt that they saw individuals with opiate use disorder fairly regularly. And 70% of them felt that it was their responsibility to treat those patients. But they referenced a few things that were getting in their way. The inadequately trained staff, insufficient time, right? Primary care providers feel very constrained with time, inadequate office space, and cumbersome regulations. And then a lot of open-ended questions. Many of them dealt with stigma, mistrust of people with addiction, labeling them as a difficult patient population. And a similar survey was done with advanced practice providers like myself, PAs and APRNs. Those individuals also reported similar items that were causing them issues, and a huge breakdown of them, more than 50%, worked in primary care. So if we were to break that down to all of the individuals prescribing buprenorphine, now this was done when there was still an X waiver in place. So they took a sample of prescribers who had the X waiver and divided them into two groups, who are prescribing and who are not prescribing, and why. And it was pretty enlightening. The top three that showed a difference between why individuals were not prescribing due to lack of confidence, lack of institutional support, and surprisingly, lack of patient need. So when they did a literature review on all of these elements in 2024, what was released was essentially that lack of institutional support was probably the number one cause across all of the different studies that was done looking into why aren't individuals incorporating such treatment into their practices, into primary care. So how can we solve this? What are some solutions to help with these three main elements? Well, I want to give you two really good resources. One is from the American Academy of Family Physicians, and it is a manual treating an opiate use disorder as a chronic condition, a practice manual for family physicians. It's a really easily digestible guide. It's only 23 pages. I say only, but some of these manuals are in the 90s, hundreds. So 23 pages is really easily digestible, and it's easy to understand with a lot of charts and graphs. And it breaks it down into these main elements: screening, diagnostic criteria and assessment, treating opiate use disorder, and it goes into detailed information on each drug, giving guidance on treatment of patients, especially specialty populations like pregnant and breastfeeding, how to do follow-up care, and then how to deal with unexpected return to use, as well as behavioral health interventions. And then also, one element that's not in a lot of other guides that's in this one is preparing your practice, how to manage workflow, how to successfully integrate OUD screening or just screening in general, as well as payment and coding, which is a big concern in a lot of those surveys, as well as resources. The other guide I want you to be aware of is the SAMHSA guide, and these are practical tools. This one's a much longer, a little bit more comprehensive, but kind of hits those same target elements. And these links will be provided for you guys after the session, including my PowerPoint presentation. So you will have all of these links at your fingertips. So let's kind of dive into the main elements that are important. Number one is screening. So when it comes to two of the three barriers that we're looking at, lack of patient need. Well, yeah, it may seem like patients don't need it if you're not screening for it. If you don't know that it exists and that it's there, you may think that it isn't existing, but in reality, we're not screening for it appropriately. So I really want individuals to familiarize themselves with the SBIRT methodology, which stands for screening, brief intervention, and referral to treatment. Then choosing an evidence-based practice screening tool. NIDA has a great resource that I will link here, and it's a chart that essentially shows you which screening tools. Now, all of these screening tools that NIDA provides in this graph are validated screening tools and are evidence-based approaches. And they show you which ones are good for adolescents, which ones are good for adults, which one focuses on alcohol versus opiate use disorder versus other substance uses. So if you don't have a screening tool already incorporated in your EHR, one of the things that you can do to help with that institutional buy-in is to get a screening tool incorporated into your EHR, which is the third element, which is incorporate the screening for everyone. If you screen everyone, this eliminates bias. And we've proven this with other conditions as well, that if you pick and choose who you screen, you're going to have biased results. And incorporating it into either the MA or the nurse's workflow when the patient is checking in is going to decrease some of that feeling of time constraints that the prescribers have. So what do you do if there is a positive screening? Well, there's multiple ways to address that. And I'm going to suggest, if your practice has not incorporated any such treatment at all, start with really small incremental changes. That is going to help it be more digestible and not feel as overwhelming for you. So the first thing to do is offer a brief intervention. Now, this can be as simple as a quick 5-minute conversation, which later on in our ECHO series, we're going to have a session on motivational interviewing, which I highly encourage you to attend. But if you can't, check out tip 34, which is brief interventions and brief therapies. And it puts this exact, the SBIRT, the screening and brief intervention, into real life elements. They give you sample questions and answers and sample dialogue with pretty well scripted language that you can use and be confident that you are making an impact in a really short amount of time. Then the next ways that you can address it is referring out, right? If you don't feel comfortable medically managing it yourself right now, then get in with your local OSAR, which stands for Outreach Screening, Assessment, and Referral. So every region in Texas has a dedicated OSAR to be able to screen patients and connect them with treatment for substance use. There's also findtreatment.gov through SAMHSA, and the ASAM, American Society of Addiction Medicine, also has a patient resources and a lookup for addiction specialists and such treatment centers. So lots of resources out there for you to be able to find places for you to refer to. And then, of course, you can choose to treat the individual yourself. And so if you have more questions about the specific medications, I encourage you to go back and look at our old echo sessions, which we had for each substance that is out there: OUD, alcohol use disorder, stimulants, even nicotine. We have it available that breaks it down into how to treat each person. But one of the elements that may not have been discussed that I know I personally have struggled with, and I know a lot of other colleagues have struggled with, is once you finally get that courage and you get that confidence to prescribe the medication, you have issues with pharmacies. So what's going on with pharmacy access? I have been told things like, oh, well, we hit our quota. We can't order more Suboxone. We can't order the buprenorphine you ordered. We don't have it in stock, etc. But what's interesting is the DEA has claimed quite loudly that they're not setting any quota limits on buprenorphine. And it's really difficult because it seems very like smoke and mirrors, cloaks and daggers, this secret system behind the scenes that's really difficult for providers to understand. Well, there was a publication that broke it down into two main elements. It's the suspicious order report system. So right now, the Support Act said the DEA needed to launch this suspicious order report system, and it's a centralized database. Well, guess what? Any product that contains buprenorphine is automatically flagged. This causes downline issues with ordering and keeping stock of bupe at pharmacies. Then you also combine that with the opiate settlement restrictions. This put actual limitations or quotas for controlled substances on the drug manufacturers themselves. So even though the DEA doesn't have any limits, these two elements cause limits. So knowing ahead of time and maybe even creating an MOU or a partnership with a specific pharmacy, or I've even had some colleagues, a Houston Heroes colleague, who took Google Maps and contacted every pharmacy in her region to figure out which pharmacy she could use and when. I mean, that took some serious dedication, but there are ways to address it to help you out before it becomes a problem. The other issue is with coding and billing. So I talked a little bit about SBIRT. There are reimbursement fees for those brief interventions. And this is just a small snippet of it that you can get from the SAMHSA website regarding SBIRT coding. Now, one of my favorite tools about integrating SUDS care and financing SUDS care is from the National Council, and there is a hyperlink. This hyperlink will take you to a decision support tool and billing modules. And you can see right there at the bottom right, you can download a decision support tool, a screening tool, metabolic monitoring, medications for opiate use disorder. And I will show you an example of what this looks like. You can download this tool, put in the number of clients you are expecting to treat in a year. It even adjusts it for no-show rates and retention of those clients. And then it breaks it down into the separate visit types and the codes. There is no better way to get institutional buy-in than showing them the money that you can make when you are treating these clients. That is an unfortunate situation with our medical system, but this is such a good tool to advocate for yourself and your patients. And you can even get a further breakdown. It also allows you to select a specific state, and it shows you what a third party, what a Medicare, what a Medicaid, and all of the different codes that you can use and who can charge for that and what the charges are. So it really is a wonderful tool if you're needing more. Now, I'm only spending 5 minutes on this, but we're going to have an entire session on billing and coding later on in our echo sessions. So stay tuned for more in-depth coverage on that. Now, if all of this feels overwhelming and you just want a plug and play model, you want to be able to advocate for a model to put into your system. These are 12 different models that are out there. You don't have to reinvent the wheel. They exist. Now, the OBOT, the beehives, essentially all the way down to integrated prenatal care, so 1 through 4 are practice-based models. And then 5 through 12 are system-based models. So this is going to involve really, really large systems of care and multiple companies and systems. But I will leave that for you here in case you want to look into those and just mirror an option that already exists out there in the world. Now, the third element, building confidence or having a lack of confidence. The best thing that I can tell you is to sign up for mentoring somewhere. Having an individual who's gone through it, who you can talk to one-on-one, is absolutely invaluable. It's what I did when I got started, and it gave me the most boost of confidence. There are 2 places I want to highly recommend. One is through UTESCA, which is hosting this echo session right now. And it's if you exist in Region 8, reach out to them and they can try to hook you up with a mentor. Otherwise, if you're outside of Region 8, go to pcssnow.org and they have 3 levels of mentoring. Then connect through things like what we're doing right now, Project Echo, or join an organization specifically for substance use to pick their brains, like ASAP or ASAM. And these are my references. Thank you all.
On the contrary, thank you, Dr. Walker, the real MVP of this session, making it through with the sore throat. Hope you have some tea handy. Um, and so I do encourage everyone to please use the chat to share your questions for Dr. Walker so that she can address them there and minimize having to unmute and speak. So the chat is open for that. Thank you all for understanding and being flexible. And thank you again to Dr. Walker for presenting. So we will go ahead and jump over to announcements. Karen, if you could please share those slides for me. Thank you, ma'am. So to claim your CME credit, you must text by midnight tonight. Text attend 100-98219 to 844-502-1338. Next slide, please. Do you have a difficult case that you or your team have encountered in your practice? CSTAT offers you the opportunity to present any challenge your organization is encountering in order to receive feedback from our hub of experts and the broader learning community. There's no need to prepare a formal presentation as we will provide you with the case form to fill out and assist you with the case presentation itself. Please email us using the email on the screen or in the chat for more assistance. Next slide, please. We invite you all to join us for the next installment of our webinar series, Thriving in SUD Service Delivery in the Post-COVID Era, on Thursday, March 20th. Dr. Verduzco Gutierrez will be discussing recent research on long COVID and substance use. Next slide, please. The Center for Substance Use Training and Telementoring, in collaboration with the Perinatal Psychiatry Access Network, also known as PeriPan, invite you all to join our inaugural Maternal Health Echo program. This initiative provides free continuing education and offers essential training, consultation, and support to enhance care delivery for pregnant and postpartum women affected by substance use disorder. The sessions will take place on the first Tuesday of every month from 12 to 1 p.m. Central Time. Join us for our very first session on April 1st. This is not an April Fool's joke. The first session will take place on April 1st, and we do look forward to seeing everyone there. Next slide, please. And finally, we do enjoy your company and do hope to continue seeing you all. Please join us at our next session on March 27th, where Dr. Dustin DeMoss will be presenting on implementing SUD services in hospital-based settings. Thank you, Karen. And so before we do move on to our case for today, I would like to remind everyone that no protected health information is allowed in the chat or in the discussion. And let's continue making this space inclusive and open to respectful dialogue. So with that, Dr. Doss, once Karen shares the case, you can walk us through it. Thank you.
Okay, hello. Thank you all for having me here today. I'll be talking about a case of opioid use disorder that really stood out to me during my time as an inpatient resident at Del Seton. A couple months ago, we admitted a 27-year-old Hispanic woman who presented with symptoms of shortness of breath, chest pain, mild hypotension, and she was unfortunately found to have really bad infectious complications that, we're all warned about that comes along with having, IV drug use. So she was found to have a large tricuspid valve vegetation that was causing severe valve disease, and she also unfortunately had septic emboli that led to a pulmonary embolus. And she had bacteremia, was growing MSSA and E. faecalis in her blood cultures. And throughout this, the biggest concern that we had was she was still currently using IV opioids, and she has had like a history of these things before. So about 7 years ago, when she was admitted to a different hospital, she had presented with similar symptoms, and here she was many years later with the same symptoms. So if you don't mind going back up to the top of the page so I can just walk through it. Sorry about that. I just wanted to give a quick rundown. But just going through the current and past substance use. So she did openly endorse having a long-standing, many years history of IV drug use, specifically IV heroin, and she did endorse smoking fentanyl. And she also was open about the fact that she's had several times where she's felt like she had an overdose and did require naloxone at the time. And she, sorry, she also had a history of methamphetamine use, but it was kind of unclear. She wasn't always very forthcoming with the information. She definitely felt like she was wary of the healthcare system, and so she gave some information, but maybe not everything. So the timeline of the use of that is not exactly clear. Same thing with things like benzodiazepines and cannabis use. She denied it, but on her urine drug screen, things were positive. So, she had like this ongoing situation, and it didn't seem like she had gotten care for it in the past or that it had been able to be directly addressed. Yeah, her primary substance use disorder diagnosis was the heroin and fentanyl opioid use disorder. It was very severe, leading to a lot of complications. Also had methamphetamine and cocaine use disorder. Her concurring mental health diagnosis was at least depression, and she wasn't getting treatment for that outpatient. It looks like she hadn't really been connected with primary care in the past. She didn't have a consistent provider, and she wasn't able to get started on any opioid use disorder medications outpatient, never had counseling. It was very difficult. And when she initially came in with all of these significant issues, she was so critically ill that she had to be taken in for immediate procedures like a valve vagectomy as well as a pulmonary thromboendarterectomy. And so during that period of admission to a couple days in, she was getting these procedures and ended up actually requiring, pain medication. So we prioritized her pain in the hospital with things like IV Dilaudid, fentanyl, and oxycodone. And by the time that she kind of got done with those procedures and got to the point of feeling better enough to discuss things like inpatient substance use treatment, we tried our best to bring that up with her. One of the things we had brought up to her was trialing buprenorphine inpatient. But by the time we got to the point of actually being able to initiate anything, unfortunately, she was already wanting to leave and go back home after her procedures. And it's unclear how much counseling and stuff she's gotten. It didn't seem like she had gotten counseling. And while she was inpatient, it was difficult for us to get her connected with our social workers for counseling and stuff like that. But one of the main things that I'll go into with the harm reduction services was kind of like a really difficult thing that we encountered in the hospital with her. Kind of as soon as she got better and completed those 2 procedures, the next steps that we were hoping was that she was going to be a good candidate for a valve replacement. However, while she was in the hospital, it was kind of a very difficult situation because she had some friends and other people that she lived with who came in to visit, and they actually brought in IV like syringes, and they brought in the drugs for her to use. And so at one point, after a visitor came by, the nursing noticed that that is what was happening, and she was found to be altered. And when something like that happens, it's like everybody unfortunately gets immediately alerted, and it feels like everybody comes down on the patient for, obviously for good reasons, because you don't want your patient to be altered and you don't know what they're getting. But then at the same time, like she already had, a lot of weariness and distress with the healthcare system, so that did not help the situation. As far as our harm reduction services go, of course, like patient was aware of how naloxone worked, and she's been through overdoses herself. So we made sure she had that. We definitely, whenever we realized that, it was ongoing and that people were bringing it in, we really tried our best to use non-judgmental language and discuss with her what her situation was, but she didn't really show interested in having reduction or backing off on use at this time, and she really did not seem like she was close to her family or anyone else like that. It was mostly kind of her friends and her boyfriend that she lived with, and they were kind of in that social situation where it wasn't maybe the best support system, because it seemed like all of her friend group was also engaged in the same activity. So it is very difficult to get away from that. And her mother was very concerned about her, but it seemed like that they had almost been estranged, and she had also been estranged from her father as well. So it was difficult to have that family social support as well. And then as far as like financial situation, she lived with her boyfriend. She wasn't currently working and didn't have insurance, and it seems like her boyfriend was the one who was financially supporting her, which, puts her in a very difficult situation, even if she were wanting to do any counseling or were wanting to do any medication treatment, so it was definitely a lot of social factors leading to this very difficult situation. And I think her PDMP had been checked, and it didn't look like she was being prescribed any opioids recently, outside of the inpatient setting. And as far as current medications, while she was inpatient, for her bacteremia, endocarditis. She was being treated with IV ampicillin, IV ceftriaxone, and she was on an IV heparin drip because of the septic emboli clot. And then she was on those pain medications of fentanyl, IV Dilaudid, and oxycodone for her pain control. So it was a very difficult situation. And after the procedures were done, she really didn't like the fact that the hospital staff had to limit her visitors from coming in because it just ended up being a very dangerous situation. So she started to feel very uncomfortable and wanted to leave, despite knowing that she could definitely die from all of these complications. And we I feel like we really tried to explain, the consequences of that, and she just still didn't feel comfortable. And we tried to offer her medications that might help curb the withdrawal. She was started on the COWS protocol to make sure she was being dosed correctly. But even despite all of that, and she still wanted to leave, so we tried to discuss the fact that we could do Suboxone therapy, we could do methadone therapy, and she didn't want to do any of that at this time. And because she was receiving IV antibiotics and she was leaving, we had to at least give her some PO antibiotics. And the biggest thing that we tried to do was tell her that if you have any symptoms, like whatsoever, you feel bad in any way, like just feel free to come back here without like feeling any judgment. But eventually she left, and it was just a really tough situation. And, I kept thinking, like, did we handle the situation in the best way? It's just really tough because what do you do when visitors are suspected of bringing in those things, and you have to kind of limit that, but obviously it kind of breaches like the patient's privacy and stuff like that. So how do you ensure their safety and still maintain that relationship with them? And then how do you support their recovery rather than doing things that feels like to them like you're punishing them? So those are all questions that I definitely had after trying to help this patient. So yeah, I would love to hear any thoughts, and I would love to answer any follow-up questions about this case. Thank you.
Thank you, Dr. Das, for this case. And yes, please, the floor is open for comments and questions. Go ahead, Dr. Chowdhury.
Yeah, the first thing I would like to say is, Dr. Das, first, thank you for presenting this case so comprehensively. So we almost can see the patient in front of us. So thank you for that. One thing before I even comment on the case, I really want to say is that in today's presentation by Dr. Walker, she was talking about how do you make it so that every provider is comfortable in providing Suboxone. I think this is the way. You're a resident, you're already interested in that. So I think catching providers early on in their training is one of the more important things in terms of making them comfortable in prescribing medications for addiction. So it's a great job from you. And then you also had some really insightful questions. I'm happy about that. I think these are questions that are not real straight up medicine questions, but more about how do you change the system and how do you change practices within the hospital setting. One of the things is that I understand the predicament where the patient comes in when they're acutely sick. So you have to figure out, what do you focus on? Do you focus on this long-term issue that they have, or do you focus on the imminent danger that the patient is in because of the acute sepsis and the valve, the heart valve vegetation and all those sort of things, right? So yes, it is a difficult thing to take care of at that time. So one of the things that I would suggest here is we perhaps we as a physician community have to normalize the use of full agonist opioids at least in the interim, when you cannot have that conversation with the patient and come up with an addiction medicine treatment plan, that it's okay for us to hold their symptoms with full agonist opioids, right? So it's okay to prescribe hydromorphone and oxycodone, and I mean fentanyl is short acting, so it's not as useful, but like, not just for pain control, but to hold their symptoms of of opioid withdrawal, right? So I think that's one of the things, because like uncontrolled withdrawals or untreated withdrawals are one of the major causes for these people wanting to have self-directed discharge, right? So I think that perhaps could have been something that can be improved, where like, when they come in, you hold them with full agonist opioids before you can like, have that conversation. Obviously withholding parameters for like their vital signs and like, their stability. So that's one of the things that I really wanted to make a point about, that we have to be comfortable giving full agonist opioids in the interim for these patients, and it's not going to worsen their addiction. It's not going to worsen their opioid use disorder. The other thing you already mentioned on your own is that non-punitive approach. And I think you, like, as you explained, it seems like you did a good job, like the team, like, the treatment team did a good job. But at the same time, the patient is not only interacting with you, the patients, actually, most of the time they're interacting with like the nursing staff, right? So it's very important to have the nursing staff be part of your plan, like, include them in the treatment planning for their addiction care. And I think sometimes that can help, because if they don't understand what's happening and they get like, spooked easily, and then that makes the patient feel like they're being judged and all those sort of things, and it can lead to that, rapport being broken between the healthcare provider, between the system and the patient. So those are two important things that I wanted to mention, and then but also like other hub members to chip in if they have any comments.
Thank
Yeah,
you, Dr.
thank you so
Chattery.
much.
Oh, sorry to interrupt you, Dr. Doss, but I do see Diana, your hand is raised. If you'd like to unmute and share your thoughts and comments, please.
Okay. Hi. Thank you, Angela. Well, thank you, Dr. Dawes. Thank you, Dr. Walker, for your presentation. And wow, I think, not want to get emotional, I think you did great with her. Because she's gonna know to come when she is ready, she's gonna come back and she's gonna ask for help. I've been in recovery for 31 years. And in 1992, I had endocarditis and I almost died. I left the hospital at AMA, went back a few days later when my mother found me. And it took another year. So when I hear people talk about endocarditis, I think it's so important to talk about, because a lot of people don't, but we don't hear about it a lot, And it almost killed me. So thank you. And so, just keep doing what you're doing. And when she's ready, she's gonna know where to go to. She's gonna know where to go to, because addiction is just so powerful. When I think back at that time in my life, I was not in my right mind to have walked out of that hospital in the middle of the night in my nightgown. It was just insanity, right? I wasn't in my right mind. And so, but a year later, I got into recovery, and by grace of my higher power, I've been able to do a lot of work as to why, and be able to come and be in the field and and help other people. And so thank you for talking about endocarditis. I did have open heart surgery 10 years ago at 21 years sober. So the artificial heart valve now, it's my tricuspid. I have a pacemaker now, and because it caused all these ongoing problems for years into my recovery, right? So yeah, I want to thank all the doctors that are here, everybody who's here, who um, everything, because we all play a part. We all play a part. We never know, like, who we're gonna touch, who we're gonna help. And I don't get to share this part. I was gonna get so emotional, but I don't get to share this with too many people, but I'm always open to share it. So if there's anybody who has experienced endocarditis or any kind of heart issues related to it, I'm so open to talking to that person about it. So my email's in the chat, and feel free to anytime to, so I think you did wonderful. Thanks.
Thank you
I
so much for sharing that. I really appreciate it, and it's very inspiring to hear what you went through.
I echo what Dr. Daw said. Thank you, Diana, for sharing your perspective with us, and that this space allows for that vulnerability and that special connection. So thank you. Dr. Miramontes, I see your hand is raised.
Yeah. So hi, I'm Dr. Dave Miramont from UTL. So when you're talking about visitors coming in and providing drugs to the patient, I think that is a pivotal moment that we have to reframe that situation. So this is looked at as a security break, as drama, as enabling. But I would reframe this in saying that your therapeutic team was not meeting the patient's needs. And it's time for a huddle. And that huddles with the resident, the attending, the nursing staff, and say, okay, so this happened. Why? And what can we do to reframe this event instead of this danger thing into looking inward at yourself and your treatment team and saying, we need to change our treatment plan. And how can we do that to be more aggressive with their care? Because this is a common thing. Patients who use drugs want immediate relief of their withdrawals, and they want immediate comfort and to be restored to their hemostasis. So if you're not providing that, anybody on this echo has been a patient, and you put on the bell and you wait 20 minutes, an hour. Oh, you need something for pain. Okay, let me go check your orders. Let's go to the computer. Oh, the pharmacy has to sign off. There's all these barriers to getting that treatment. And that's unfortunately in our institutions, something that is ingrained. That immediacy to manage the symptoms is part of the problem with our interactions with these very complicated individuals. So I would just say reframe that into a different way of looking backward on yourself and your treatment team. How can we meet this need differently so that she doesn't have to use her friends as a source of relief for her withdrawals?
Thank you, Dr. Miramontes. And I see Dr. Walker gave you some virtual applause for that, so she is in agreement. Sorry, I just saw someone's hand raised, I think. At any
Oh,
rate, oh,
I
Dr.
mean,
Shorter. Yes,
yeah,
okay.
I'd love to piggyback on the comment that was just made. I was thinking as we heard the presentation today, which was really quite touching and excellent, and thanks everybody for their comments, that while we were seeing and watching management of the opioid use disorder, the urine was also positive at the time of admission for cannabis as well as benzodiazepines. And so I was wondering if and how withdrawal from cannabis and benzos was also addressed. We are also dealing with someone who's reporting a longstanding history of methamphetamine use, and to what extent is that being addressed as well? Um, Psychiatric consultation during this context can oftentimes be helpful getting in touch with the CL service, the consultation liaison service, particularly when you have a diagnosis of depression. And the comorbidity of heart disease and depression is extraordinarily high. And so getting the psychiatric service involved sooner rather than later can sometimes help to perhaps offset and provide opportunities to connect and really provide that holistic care that we are really trying to. I recognize, as was mentioned by Dr. Chowdhury, that we have to sometimes prioritize the thing that is most life-threatening. And at the same time, by perhaps focusing solely or exclusively or primarily on that, we miss these other opportunities to engage people and help them feel kind of cared about, right? Like, so I see you more as just opioid use disorder. I recognize that some of your discomfort might be actually anxiety that you're experiencing, not just from being in the hospital, but also from the fact that you were taking benzodiazepines before you got here, and now you're not taking benzos anymore. How are we managing or addressing that? And so this idea of really like taking a look at each of the substances that's in play and saying, how am I managing this as well can sometimes open up these opportunities for additional connection with people. But really have appreciated the nicotine. Also, my gosh, thank you, Dr. Chaudhry, for pointing that out. Nicotine replacement as well. Thank you, thank you, thank you. Excellent point.
And I think another point I really wanted to make was with regards to, like, the practical approach of, like, allowing people to meet the person, because also you're not, like, it's not a prison, right? So so you have to balance that out. So a way to deal with this situation would be that, just like you have family discussions, right? So you can have a list, or, like, one or two people who are on the safe list of visitation, and then you can have almost like a family discussion with them, like, this is what the situation is, and this is why, like, the risk of harm from substances is there for her, given that she's already coming in with sepsis and with, like, a valve agitation, and how you will be addressing the withdrawal symptoms, and then those safe lists, that list of safe people are okay to visit the patient. I mean, practically, you might have to limit access to, like, like a friend who just out of nowhere appears, but if they have, like, a select few people who are still able to visit them, it just, like, make sure that their social needs are also met while they're in the hospital, because it's like a demanding time, it's an emotional time when someone's in the hospital.
Thank you, Dr. Shorter and Dr. Chaudhry, for your comments and thoughts just now. Dr. Ramesh, if you could unmute and expand on your kudos for Dr. Das, please. I think your comment is wonderful, but I'd like to give you the opportunity to tell her yourself.
Yeah, great job, Abipsa, in presenting this case. It sounds like you all presented a message in a unified way that was non-stigmatizing and supportive to the patient. And I think it is a really good idea to get nursing involved in those discussions as well, because you're not quite sure what your care team might be saying to the patient and what someone else on the care team might be saying to a patient. You want to make sure you're not sending mixed messages, or no judgment is kind of coming through. And it sounds like you did do that. I love the reframing idea also that was brought up by Dr. Miramontes. And then one thing I did want to point out is we do have peer coaching services at Dell Hospital. I can message you afterwards to tell you a little bit more about it. For patients for someone with lived experience who has been through what this patient has been through, just to talk to them about any support that they may need, even if the patient doesn't really want to talk about recovery just yet. It's just having, like, another person in their corner who has been where the patient has been, can help them navigate kind of the complexities of this healthcare system, and just be a supportive voice for them and an advocate for them.
Thank you, Dr. Ramesh. Any other comments or questions from anyone in our learning network?
Yeah, this is John coming. I just want to echo a point that Dr. Walker made in her presentation about primary care, which is about systems change, and just acknowledging that taking care of patients in environments which do not yet have policies that support patients who use drugs in ways that we've talked about in a lot of the comments, it comes with a lot of moral injury, because it can be better. And the work of changing those systems is also part of practicing addiction medicine in general medical settings. And just like Dr. Walker lined it up, there's resources out there, and there's a community out there, like our conversation today, that can support you, because it's really hard to do it alone. So I just wanted to point that out. And then also, just again, thank you, Dr. Ramesh, for pointing out the power of peers. Recently, I was seeing a patient in clinic. We worked with an amazing peer, and this patient was in crisis. And I had 50 ideas about what could help, and we wanted to offer that menu of options. And then our peer came out of the room and said, "She needs a Dr. Pepper." That was the most important thing that happened. Yeah, just as a very concrete way that love shows up when you have peers there, and that often escapes our clinical gaze. So thanks everybody for all the comments today, and thanks for this great case, Dr. Doss.
Thank you, Dr. Weems. Dr. Chowdhury, can you expand on the podcast link that you just shared, please? And then I'll leave the mic with you to give us a summary of recommendations.
Absolutely. Actually, I'll not take credit for this podcast because Dr. Beams introduced us to this podcast. This is the ASAM Practice Pearls that specifically on in-hospital substance use management, and it actually gives like real practical insights on how you can create a stigmatizing environment inside the hospital. How can you create a collaborative team between the physicians and the nursing staff and patients and their loved ones, and how do you address specific substance use disorders within this setting. So I think this is a podcast everyone should listen to, which I'm definitely going to listen to like right after this hub. And then in terms of a summary for today. So I would actually like to start off with what Dr. Walker presented on, and I think she did a great presentation filled with resources. So I think this is one presentation for which we should definitely have the PowerPoint sent to everyone. Thank you, Dr. Walker, for that, and thank you for actually doing it while you're sick and you couldn't talk. So kudos to you. So one of the things is the importance of we always thought that the X waiver was a big barrier, and then we worked with the DEA and the X waiver was done away with, and we thought this is going to dramatically improve access. And what ended up happening is it did not improve access to the level that we expected it to. And this leads us to the fact that there are certain barriers that are in place still. And Dr. Walker clearly presented that one of the main barriers was the physicians and advanced practice providers not being comfortable with providing this type of care, and then some institutional barriers and time constraints and financial constraints that providers had. And in terms of resources, the best thing Dr. Walker did was actually provided real guides. So the AAFP's guide, which is I'm a family physician, so I go on the AAFP website a lot. So this is a very good guide and very simple to understand and very simple to implement. And then the SAMHSA, which is a more comprehensive guide on making an outpatient treatment program for substance use disorder. And I think one of the more important thing, if we cannot do anything, we should implement some sort of expert or screening, brief intervention, and referral to treatment program into our practices. This is very simple to do, not very time consuming. And this is something, as Dr. Walker pointed out, that can be incorporated within the workflow of the nursing staff so that the providers don't feel overwhelmed by it. So thank you, Dr. Walker, again for all these resources. And I think we'll share these PowerPoint slides with everyone in the group. In terms of the case today, the first thing that we learned is that residents can they are the future. So one of the barriers that we need to lower is that we need to start teaching about addiction early on in the training of medical professionals. But more importantly about this case, a few pointers that we can do to improve substance use care for people when they're in the hospital. One is that we have to have a collaborative care environment in which physicians and the nursing staff and the patient and the loved ones are all working together towards an addiction treatment plan so that everyone is on the same page and the same message is conveyed to the patient and they don't feel like they're getting mixed messages. The other thing is we need to be cognizant of the immediate negative feedback that comes with the withdrawal symptoms, and we need to be okay and we need to normalize treating withdrawals early on, and then an addiction treatment plan can be made later on when the patient is more stable, because that can lead to the breakage of rapport and the patient wanting to leave the hospital in a self-directed manner. Don't forget small things. So nicotine, cannabis withdrawals, anxiety, all of these things can play into the patient being on the edge and not wanting to stay in the hospital. We have to make sure that the environment remains non-punitive in nature. And we also need to make sure that the nursing staff is involved in making of these plans and in implementing these plans, so that they have, like, joint ownership, and we have a unified message to the patient.
Thank you for that excellent summary, Dr. Chowdhury. Thank you all for attending today's session. As a reminder, to claim your CME credit, you must text by midnight tonight. Text attend 100-982-19 to 844-502-1338. We also kindly request that you complete the post-session survey using the link in the chat. And as a reminder, our presentations are added to the iEcho program under the Content tab for your review and reference after sessions. Thank you again, everyone. We look forward to seeing you at our next session, and have a wonderful rest of your day. Bye.